Thank you. Thanks, Duran. Thanks, Kathy, for organizing. Thanks, Quan. That was a very challenging topic. All those bones and ligaments. My brain's a little fried. Mine's going to be easier. There's one tendon we're dealing with. It's the biggest tendon in the body. Okay. So this is the. We're going to focus here on Achilles tendon ruptures. Not diagnosis, but more how we treat them, because a lot of this trend now is to treat them non-operatively. And this is very important for physios, because it's really important for you guys to understand who treats them surgically and non-operatively, and how to treat them non-operatively. Have you all, I'm just going to poll the audience, you all have seen Achilles tendon ruptures in your practice and you've sent them to the surgeons. How many have you seen lately treat non-operatively? A few. And what about the operative ones that they do surgery? So it looks like, probably a little bit less treat them surgically and more non-operatively. So it's a really big trend lately. So we're going to dive into why that is and what's been happening lately. So if you look at this slide, this talks about how we generally treat Achilles tendon ruptures. And it's going back years and years in the past. So, we used to treat them non-operatively, non-weight bearing, in equinus for 6 to 8 weeks, no walking on the leg. Now lately we've been doing more early weight bearing, early range of motion. Operatively, you can treat it open, or you can treat it minimally invasive these days with small incisions and anchors. So if you look back why we started changing to surgery, and this is back in the early 2000s, there was a Cochrane meta-analysis which looks at all the literature on what was happening with Achilles ruptures, and they compared surgical treatment to non-operative treatment. So they looked at 14 trials, and they found that the risk of re-rupture with surgery was 3.5%, and non-operative treatment was 12.6%, a lot higher. And with surgery, there is a higher risk of skin and wound complications, and obviously you don't have those complications with non-operative treatment. Now, it's important to look at what they looked at, because most non-operative trials here used non-weight bearing in this review. So they also looked at their results in terms of their outcomes. So it's important to see what you're studying and what you're evaluating. In this, they looked at the re-rupture rate and they looked at wound complications. But what we all know is that we deal with a lot of people, like Duran was saying, even elderly people these days that are athletes. They want to get back to running again, and it's important to get their strength. And what happens when the Achilles tendon ruptures is you can lose your strength. And so we want to restore strength and not just worry about re-ruptures. And we want people to return to sport. When I did my literature search, this was an interesting article, I thought, because they looked at outcomes in terms of what's called the heel rise work test. And so most articles report equivalency with function regardless of treatment, but maybe their tests are not crude enough. They look at the ability to stand on your toes. Okay, that's doing that once, and perhaps everyone can do that, and that looks okay. But what this article described is called the heel rise work test. So they said, can you do this, but can you do this many times, and how much can you do it, and how much work can that Achilles do? And they found that, that's a good measure, because once you measure that, you might notice a difference. So they looked at a study here, and they showed that when only measuring one heel rise, then all patients restored their function, about 95% of them. But when measuring the heel rise work with repetition, the Achilles only recovered about 76% of function. So when we look back at the Cochrane database study, they showed a strength deficit of the calf musculature after an Achilles rupture in anyone with surgery or anyone without surgery. And they showed that this was a loss of about 10 to 30%, and it's difficult to overcome. So also when we're talking about any of these treatments, we also still feel like we're not doing the ideal treatment, and there always is some ways to get better. So how can we make this better? So the current trends, we call it, are functional bracing. And what we mean by that is immobilizing, but using early motion and early weight bearing. There's also non-operative approaches we can use, or surgical treatment. So what do we mean by functional bracing? So we'll get into that. Early motion, early weight bearing. It's really unknown which of these factors helps more to influence healing, but we do think that they help the Achilles tendon to heal better. Perhaps it prevents the muscle atrophy, or there are cellular changes that enhance the healing process, and there's the favorable influence on the maturation of collagen fibers with tendon healing during healing. So with early motion, we know that it leads to improved healing, and it perhaps leads to a release of growth factors. We've studied this in animals, and it shows that there's a 3-time increase in strength of the Achilles tendon with a dynamic rehabilitation. So why early weight bearing? Well, we think that mechanical load improves tendon healing. We've done randomized studies to show that weight bearing groups had, first of all, because you can walk, I mean, it's very hard to non-weight bear, and so allowing someone to walk is better for their quality of life. They also get back to quicker return to walking, and we found with these studies that there's no detrimental effects to the Achilles tendon if we let them walk. So when we look at some older studies, they definitely favored surgery. For this one, for instance, there's a reported re-rupture rate of 1.7% in patients treated with surgery and 20.8% with non-surgery. When we look at the non-surgical cases and how they were treated, they were put 8 weeks in cast immobilization. So they didn't do this early weight bearing, early motion. And with surgery, they did. When they did surgery, they had a movable brace, and so they actually let those people move. And so we realized maybe that's what's helping the tendon heal better rather than the surgery itself. Recent studies have utilized different protocols where they do early range of motion, early weight bearing, and in both groups, non-surgical and surgical, and showed that the results between the surgery and the non-surgical groups are fairly similar. So here, if we look at these studies, they look at showing that non-operative is equivalent to surgery. And by the way, in my handout, there's a lot of literature. I've pretty much outlined all these articles and the summaries in there as well, so you don't have to write any of these down. But it just kind of summarizes all the latest literature on this. The last page of my handout is also, I'll show you later, but my protocol that I use for all Achilles ruptures. So if we look at this, what this shows is that in 2010, this article showed all re-rupture rates were equivalent. They had the same scores in strength and range of motion, and they did a meta-analysis in 2012, which showed that with functional rehab, early range of motion, the rupture rates were equal. And with surgery, they had a risk of wound complications. So their conclusion was that functional rehab and early range of motion can yield equivalent re-rupture rates and no differences in strength. And with the risk of surgical problems, well, maybe it's probably better to do non-operative treatment. Now, a lot of studies showed early weight bearing to be helpful. All of these studies showed that there's early weight bearing compared it to non-weight bearing. And they showed that after surgery, weight bearing allowed a better overall health with fewer limitations and no differences in outcome. So studies also here reported early range of motion that's favorable, showing that early range of motion resulted in a shortened rehab time, and there was no complications, and a decrease in the re-rupture rate, which might sound counterintuitive. We're starting to move it early, we've just repaired the tendon, but there's actually a decreased rupture rate, maybe because of the enhanced healing. Now, as we say all this, there are some studies that still favor slightly surgery. And we look at these studies, they show there was a meta-analysis in 2010 showing the re-rupture rate of 4% in surgical and 12% non-operative. And the surgical group did better in muscle function tests. And that's the study we talked about, the heel rise work test. And so they showed a difference because they showed that the work of the tendon was stronger with surgery. In 2011, they compared surgery to non-operative with functional rehab, and they also showed a better re-rupture rate with surgery than with non-operative treatment. And surgery was supported in this article, especially in patients less than 40 years, in order to increase their strength and get a better muscle function. So what I take home from all of this is that surgery seems to be more reliable for strength, and I usually consider surgery for young, active patients where I think strength is very important. There are other issues to deal with today, which we'll go into, but someone who has a delayed diagnosis. So if you have someone who's seen about 1 week after and they were told to be treated non-operatively, and some people, I've seen this happen, they say, well, you don't need surgery, and they let them walk. They don't give them a brace, they don't give them a boot, and they come into the office and they're just walking. And so you can imagine that tendon is now stretched out and starting to heal. And so it's very hard to get them to restore their muscle tension relationship and get their strength back. And so anyone with a delayed diagnosis, surgery should probably be considered. There's an issue also about compliance with instructions, and I find this to be the case. If you operate on someone, people listen to you a lot more because that's a more serious situation. If you have an Achilles rupture and you got lots of pain and you're told you don't need surgery, well, once that pain goes away, patients may be more cavalier with what they're doing, but this is not a good situation for that. Patients who have Achilles ruptures and are treated non-operatively, they need to adhere to strict protocols in order to get them to heal properly. And so if someone's non-compliant, maybe it's better to do surgery. In non-operative treatment, you can do this if you see the patient within 48 hours. Most studies talk about non-operative, but they want to get to them early. So within 48 hours is good enough where we can put the foot in equinus and get the tendon to stick together. Older, less active patients where you're not relying on strength restoration, I think those patients you can treat non-operatively, and certainly patients who might have wound complications and diabetics or patients with heart conditions or smokers, you would consider non-operative treatment. So my non-operative treatment, and again this is in your handout, but the protocol is from this article, and so it's a very strict protocol, and I actually think that it's more strict than my surgical protocol for that reason, that patients tend to be a bit more cavalier. So they start out, everyone starts out non-weight bearing for 2 weeks in a boot in equinus. Not to plug this boot, but I like it because you can dial in the range. You can dial it into plantar flexion, and it holds it nicely in that position. So at 2 weeks they can start partial weight bearing, and at 4 to 6 weeks they can start full weight bearing, and I don't change the position of it until 6 weeks. Once at 6 weeks I start to change the position more to neutral, and at about 8 weeks they can start walking without the boot. So again, non-operative treatment is active treatment. Patients need this guidance and they have to be compliant, or else they're going to lose strength in their Achilles tendon. So it's actually harder to treat, and I usually see these people every 2 weeks to get them on board and make sure they're doing the right things with this boot. And also, it's, as John reminded me, they should not remove the boot. You know, it's like treating a fracture. You've got to keep the tendon together, or like a mallet finger. Like once you take it off and that tendon stretches, you kind of lose what you gained from using it. Okay, and because these people are all at risk of DVT, then you really should give them some DVT prophylaxis. So just yesterday I had this woman who years and years ago had a pregnancy, and she had a DVT, and she was placed into a boot for an ankle fracture, and she didn't walk on it for like 6 weeks, and I saw her and I said, you know, we really should just scan your leg just to get an idea of what's there, and she wasn't having any pain, but she had a DVT, and so it's really important to check on these, I think, because they are there. So with my operative treatment, I usually treat this open, and I basically do a standard posterior medial incision. The Achilles tendon has a surrounding paratenon And this protects the tendon. So we incise the peritoneum, and in order to repair it, we use what's called a Krakow suture. We find the tear, and it's important, if you look here, could we do a pointer, Duran, or no? That way? Ah, there we are. Okay, so when the sutures are put together, it's important that the tear gets shortened the way it should be. So when we tie these, we don't want to just do end to end, because that would make it too long. So we have to make sure we see where the original tear was and restore all of that tension that we lost. Okay, so when we do surgery, look for that. What we also do, and I learned this from John, again, John, you've taught me a lot in my years, thank you very much. So, but we used to use all these non-absorbable sutures, and in America we do a lot of non-absorbables because they're strong, but these are absorbable sutures that we use, and they absorb completely. So if there's any chance of an infection, once they absorb, there's no foreign material there to harbor the infection, and it's gone. So I think we get a lot fewer problems in terms of infection because of that. So they're all absorbable sutures. We do what's called a fasciotomy as well. This is the peritoneum that surrounds the Achilles, and it protects the Achilles. When you do surgery from the top and you try to close the peritoneum, it's very difficult because the Achilles was ruptured, it's bigger, and there's no room to close it. And when I was a registrar, and we used to really try hard to get it closed, and we couldn't. And then John again taught me, we just cut the fascia below it, and then it allows the back you can transfer it over the back and protect the tendon. And so it just makes it so much easier and protects the tendon. And I rarely have wound problems with my repairs now. So this also brings the muscle belly below it, called the flexor hallucis longus, closer and allows for more healing. So it's a good technique that we use. When we do this, we also use some circumferential sutures just to add some strength. And that's basically it. So the peritoneum is closed and the skin is closed. So when you're treating these in physio after surgery, this is basically what we have right here. This is the construct that we use to repair it. There's lots of sutures across it. They're absorbable sutures. We do need to be a little bit careful with it in the first, say, 4 weeks because they may break. They're weaker than non-absorbable sutures, but the benefit is to reduce the risk of infection. So after surgery, we do the same protocol that I just showed you with non-operative treatment. It's the same exact protocol. So after surgery, they go non-weight bearing for 2 weeks, and then they go in equinus for 6 weeks. We change it to neutral, and then the boot gets taken off. So in summary, functional rehab is really important to reduce re-ruptures and help with the rehab. But surgery, I think, still has a role, and the role is to ensure calf strength and in young, active, healthy patients. Non-operative treatment can work well, but you need to have the right patient and you need to have treatment done early. Thank you very much.